Hi, I'm Alex Gamble. I'm an internist, psychiatrist, and palliative care physician practicing at Phelps Regional Medical Center in Rolla, Missouri. And I wanted to just talk to you a little bit today about capacity evaluations. So the first thing when we talk about capacity, I think, is determining the difference between capacity and competency, since often both of these terms will come up in evaluating patients' capacity, and sometimes they're used interchangeably. It's important to understand the difference and understand when we want to consider one versus the other and who's appropriate for making those assessments. So we'll start by talking about competency. So the first question that comes up is, who's the appropriate person for making this evaluation? In the case of competency, it's really judges. So competency is a legal question that's adjudicated by a judge. It covers all questions or decisions and is effectively permanent. So it covers any decision that a patient or a person might have to make for pretty much all the time thereafter. There are certain rare cases where someone who's declared incompetent might eventually have that competency declaration reversed, but in general it's considered as sort of permanent. When we're talking about capacity, on the other hand, this evaluation can be done by pretty much anyone, or at least anyone who has a little bit of training or knowledge in doing this evaluation. We're going to talk about what's included in that evaluation here in a second. It's in reference to a specific question at a specific time. And so, by its nature, whether or not someone is said to have capacity to make a decision can kind of change. So this, I think, is the first thing to know. Often someone might say, well, I don't think that patient is competent to make that decision. And competency questions are really decided on by courts. It's a much longer process. Medical findings or the findings of mental health professionals or other medical professionals may be called upon in the course of making that evaluation. But in general, that's a final decision that's made by a judge or a court, whereas capacity is question-specific, time-specific, and can be evaluated by anyone, a nurse, a social worker, a physician. It doesn't have to be a psychiatrist, doesn't even have to be a doctor, although often physicians and particularly psychiatrists are called upon to make those assessments because of concerns about liability. Very often when we're talking about capacity evaluations, we're talking about patients making decisions that we may not agree with or think are safe decisions, and so we're trying to get more people sort of on board for that evaluation. But really in practice and in theory, the evaluation itself is actually quite simple. So when we're talking about evaluating a patient's capacity, what is it that we need to query? So if you just go on Google and look for papers on evaluating capacity, there's lots of good literature that's out there, and the approach is pretty well conserved. It's about 4 things that we want to assess to determine whether or not a patient has capacity for a question. So what goes into a capacity evaluation? Well, we said that it's question specific, right? So what we want to see a patient be able to demonstrate to assess whether or not they have capacity to make a specific decision, whether that's to undergo a treatment or forego a treatment, whether that's decisions regarding their discharge plan. We want to see, number one, do they understand their situation? In the case of treatment, that might include information about their diagnosis, their prognosis, kind of what's going on with them in this moment. If it's a discharge question, so it might be a patient who's wanting to discharge and it would be an against medical advice discharge. Do they understand the medical specifics of what's going on with them? Do they understand, number 2, the risks and benefits of the proposed treatment? Do they understand the risks and benefits of alternatives? And number 4, can they express a clear preference? So basically, does the patient understand what's going on, the situation that they're in, what's at stake? If somebody's in the middle of having a heart attack, do they understand the nature of that that's a particularly life-threatening situation? Do they understand the nature of the proposed treatment? In that heart attack case, it might be to take them back to the cath lab. Do they understand the risks of catheterization as well as the benefits to open this blockage and hopefully keep them from dying? Do they understand the alternatives? They could have conservative medical treatment in the case of that heart attack. They could forego all treatment. Do they understand what the risk of death might be sort of in that case? And then can they express a clear preference? with regard to a specific question at a given point in time, if a patient is able to do these 4 things, if they can demonstrate an understanding of their situation or their diagnosis, if they understand the proposed treatment, the risks and benefits, the alternatives to that recommended treatment, and the risks and benefits entailed, and the patient can express a clear preference, then that person is said to have capacity with regard to that question in that point in time. Now, it may be that at a later time, if we think about a delirious patient, that's a pretty easy example, the patient may lack that capacity. So if we're doing this evaluation and someone's in a pretty clear window, we may say, okay, yes, at this time they were able to make that decision. We may come back a few hours later and they may be totally confused, they may be delirious and out of their head, and if we try to go through this set of evaluations with them, they may not be able to really hold on to the kind of information that's necessary there. And so that can change over time. As well, different questions require a different sort of level of capacity. You may consider, situations where the risk is very low. It may not take a lot of cognitive capacity to understand the nature of their situation and to make a decision with something simple like taking a Tylenol. Whereas going for a really big surgery, they have to hold a lot more pieces in their mind. So if we just think about their cognitive capability, it takes a lot more for something more complicated. And they may have capacity to say, accept the Tylenol or reject the Tylenol, but maybe not have enough going on cognitively to really make a decision about something that's a lot more complicated. This gets to something that I think is important, although not always really discussed. And this is, I think, especially a critical idea to hold on to for someone who's going to be in a position to evaluate capacity for a patient. And the idea is this. As I was describing, there's kind of a variable amount of capacity that's needed depending on the kind of question. And so we think about risk and benefit and how that affects capacity, or how much capacity someone needs to make a decision. So we think about situations where the risk is very high and the likely benefit is, low or somewhat low, compared to where the risk is pretty low and the benefit is very high, right? So an example of something where the risk is high and the benefit is low might be a very invasive surgery for a patient with, a late stage cancer where we don't really have good treatment options, where doing this procedure may confer some benefit, but the risk of it might be very high to the patient. Versus, an easy example for something with low risk and high benefit would be something like Tylenol. Assuming that their liver is okay, they're not there for Tylenol toxicity or overdose, and they've got a little bit of a fever. So the benefit is the Tylenol is very likely to kind of fix that fever, and the risk of the patient is very low. So there's kind of an inverse relationship here. In a case where the risk is low and the benefit is high, we would say that a patient needs very little capacity to assent to treatment and a lot of capacity to refuse. And that's the opposite relationship in the other case. In a case where the risk is very high and the benefit is pretty low, we would say that they don't need much capacity to refuse and need a lot of capacity to accept. Now, why is that important? Why is this something that's important for us to kind of zoom in on? Well, for one thing, how do we define risk and benefit, right? What constitutes the risk to a patient or the benefit to the patient depends on how we think about what's good or what's potentially bad or injurious to that patient. And we, as providers, have a really specific bias toward what's good for patients. In general, our bias skews to whatever prolongs life, whatever fixes problems that are going on with patients, medical problems, and really prolonging and sustaining life are good things. And anything that doesn't do that is considered for us largely a bad thing. Whereas patients might have a really different perspective on that. Their sense of good and bad might weigh on whether or not it keeps them in the hospital longer, whether it gets them back home faster, whether it allows them to do things that are important to them. So risk and benefit might be defined differently between providers and patients. And so as we set these barriers, as we set these guidelines on what's going to be required for a patient to say yes or no to something, there's an intrinsic bias in the person that's doing the evaluating. And I think this is important to understand because the patient is at a significant disadvantage in this evaluation, because what's important to them and how they assess risk and benefit might be very different than us. Now, you could say, well, an appropriate evaluation of capacity will have that wash out, because one of the 4 things that we're evaluating is their understanding of risk and benefit. If the patient evaluates risk and benefit differently than we do, that might come out in that explanation. But potentially not if we're not looking for it. And that's why I think it's important, as people who might be called upon to evaluate capacity, to be very thoughtful about the way in which the whole process and the system skews in our favor, potentially against the patient at times. So we think about places where the risk is high and the benefit is low as patients not needing a lot of capacity to refuse that kind of treatment, because again, it's sort of in our assessment, a reasonable person might have a good reason to reject something where the risk is high and the benefit is low. And conversely, in a situation where the risk is very low and the benefit's very high, we'd say, well, you probably don't need a lot of capacity to assent to that treatment, because again, most reasonable people would probably go along with that treatment or accept that treatment, because again, the benefit overall looks good. But again, you can conceive of, and it might be something to talk about with sort of colleagues or peers, thinking about scenarios, clinical scenarios that might come up, where this might get turned on its head a little bit depending on how you think about risk and benefit overall. And very likely in some clinical settings, you've seen some challenging situations with that in particular. But to me, the evaluation of capacity is very straightforward. Does the patient understand the situation that's in front of them? Do they understand the proposed treatment, its risks and benefits? Do they understand the alternatives to treatment and the risks and benefits? And can they make a clear expression of their own preference with regard to what should be done? If they can do those 4 things, at that time for that question, they've done it. Understanding the underpinnings of that, though, is critical to making sure that we're not coercing patients or sort of unduly putting strain or distress on them because we think about things differently than they do. So I think it's important to understand not just what the patient's preference is and do they get the situation, but how do they think about risks and benefits, and how does that impact where this is at. In terms of the higher levels of cognitive capacity for much more complex decision making, a lot of that comes out in the wash in the course of the assessment itself. You can think about a patient who maybe is, again, confused, delirious, a patient with dementia, where they have a lot of difficulty holding a lot of different ideas in their mind, something that's very complex, that has a lot of risk associated with it. They may just not be able to, because of their cognitive status, hold those pieces together. And so in the course of that easy 4-step evaluation, we can kind of see that shake out. Now again, that same patient may have capacity for other questions. This is not a global evaluation. It's specific to question and time. And anybody can evaluate it as long as they can keep those 4 principles in mind. So this has just been a brief summary of evaluating capacity for patients in the hospital or other settings. And I encourage you to continue on your reading journey and improving your education on this question. There's lots of good articles out there about capacity, but all of them kind of center around these same central concepts. And really be thoughtful when evaluating capacity in patients to the way that they're often disadvantaged by the system because of our bias to what good is and what risk is for patients. Thank you so much for your time, and I hope this has been very helpful.